to the session that is looking at mental health, and it is a potential intervention in violence prevention. In the interest of time and so that we can hear the discussants, I'm going to move right into their introductions and start this. They each have about 15 minutes, and then we'll have question and answer at the end. And I'd like to, as we had with the last discussion, hold the questions to the end of the presentations, all the presentations. So our first speaker is Colleen Berry. She is Associate Professor and Associate Chair of Research and Practice in the Department of Health Policy and Management at Johns Hopkins in the Bloomberg School of Public Health. Her current research, much of it involves implications of the different aspects of the Affordable Care Act on persons with mental illness and or substance use. And I think this will be particularly interesting. We've heard a lot so far about different sources of violence and risk factors for violence. Now we're going to start getting into some of the things from a mental health perspective maybe we can do to reduce those risks. So Colleen, please.
Thank you for that introduction. It's a pleasure to be here today. So I want to both begin and end my discussion with a focus on stigma, because I think that stigma perceptions about individuals with mental illness are fundamentally connected to the design of a robust mental health services financing delivery system in the U.S. and the extent to which I, like Director Insel, feel always uncomfortable when I see the titles of forums like this explicitly linking violence and mental illness, because I do worry about this stigma aspect quite a bit. So I want to frame this in terms of how the broader public thinks about these kinds of images that we see so prominently in our media, and that in fact fundamentally affect the way laws are written that affect services and policy. And to begin with, and Paul Applebaum referenced this study that I did last year with colleagues that was published in the New England Journal of Medicine, but just to highlight the point here that with regard to serious mental illness, public attitudes are becoming more stigmatized over time. 46%, and this was the statistic that Paul cited, noting that their perception was that people with serious mental illness are by far more dangerous than the general public. And then I include two of a variety of different social distancing measures we might look at with regard to this: the desire to work closely on a job with someone with a mental illness, 29%, willingness to have someone with a serious mental illness as a neighbor, 33%. And this is, I will note, affected by whether you yourself have had an experience with a mental illness, either directly or through a close friend or family member. So this is the backdrop, I think, for thinking about the connection between public attitudes and broader support for a robust mental health services system in the U.S. With regard to prevalence, and treatment, many people experience mental illness. This is a theme that we've heard over the last day. Ron Kessler tells us through his work that lifetime prevalence of major mental illnesses meeting diagnostic criteria among U.S. adults is 46%, and seeking care for mental illness is quite common too. 1 in 5 seek professional care for mental health yearly, and 1/3 of us over our lifetime. And I think these facts are important to remember in explaining why virtually all of these high-profile stories we see can be linked to a person's abnormal behavior, psychological problem identified, problem that required prior mental health treatment. So broadly speaking, having a diagnosis of a treatment history is not a very specific, as we've heard, or perhaps a very useful predictor of violence. Again, as we've heard, most people with mental illnesses do not commit acts of violence, and violent acts aren't committed by people with a diagnosis of mental disorder, and a very small share of the population, less than 2%, meet the diagnostic criteria for severe and persistent mental illness. The strongest relationship with violence, even within this very small group, is with subgroups of persons with severe and persistent mental illness. Adults who had conduct disorders in childhood. We've talked about the issues related to co-occurring substance use disorders. And even among these highest subgroup, most people are not violent. And I've been so thankful that other speakers have reminded us that people with severe and persistent mental illness are more likely to be victims than perpetrators. So with all of this background, can access to services impact violence? So the two types of sort of service interventions that I hear about most often are, one, a return to a broader institutionalized system of care in the U.S. And, you know, I think maybe this is sort of romanticizing the past, and we should always be reminded not to romanticize the past. But research suggests no clear association between deinstitutionalization and patterns of violence among people with severe and persistent mental illness. And we don't have time to discuss them in detail, but we heard some about the serious civil rights considerations and challenges associated with any change in the way we are approaching sort of to roll back history in this regard. The other issue that we hear a lot about in this context is whether there's a case for broader universal screening. And this is very problematic to the extent that this is a low specificity predictor, and we could identify far more people than the system could handle in terms of resources and appropriateness for treatment, and frankly divert resources away, which are already quite limited, from the areas of most graded need with regard to access and service delivery. So neither of these broad brush approaches are likely to be very effective in reducing violence. I think that there is a role, and we've heard some about this over the last day, for targeted improvements in access to services that could help modestly. Effective treatment for conduct disorders in kids could reduce violence. Really a whole range of interventions that have been established and haven't been well implemented related to co-occurring mental health and substance use disorders. Certainly suicide prevention-oriented services, and a real robust effort is needed to develop, evaluate, disseminate interventions to address specifically severe and persistent mental illness associated with violence. This is really something that is lacking at this moment. But I want to make the larger point that there are lots of reasons to improve the behavioral health system in the U.S. That include but go far beyond concerns about violence, and this includes undertreatment, inappropriate treatment, major problems with quality of care. In fact, compared to other areas of healthcare, a much less robust infrastructure for even measuring and tracking quality. And this becomes increasingly problematic in the context of payment reform that involves performance-based performance metrics and performance being tied to payment, fragmented a system with regard to care delivery, fragmentation mirrored in financing and payment systems, important provider supply issues, lack of insurance, underinsurance. And here I'm just going to give you a quick snapshot at the percentages of spending covered by various payers. And you can see that with regard to payment for mental health services, it looks quite different than the healthcare system overall, where there's a much higher reliance on private insurance and Medicare specifically as payers. On the mental health side, a larger role for Medicaid, and this becomes important when we talk about Medicaid expansions and the role of the ACA in a minute, and even a quite different financing structure when you compare mental health and substance abuse treatment, which are often inappropriately sort of thrown together. This looks very different, and you can see in particular for substance use a much larger share of financing coming through what is called other state and local. This is block grant funding. This is other local and state sources of funding. This is changing very rapidly in the context of a really evolving system of financing. And here is just a little snapshot to give you a sense of how the world has changed. This tells us that since the period prior to the creation of our major health safety net programs, Medicare, Medicaid, there was really no role for private insurance of mental health care, and the bolus of financing came through the states. This changed very rapidly, quickly after the creation of these major entitlement programs, down to 30% in 1971. And you can see this pattern that I mentioned a minute ago, which is a relatively quick increasing role of Medicaid, and it's even higher. This comparison ends in 2001, but even higher today in a reliance on the Medicaid program as a major source of financing of mental health services. And these are in current dollars. You can see a big increase in current dollars in spending on mental health services over time across these payer categories. Here is just to give you a quick snapshot focused on the first row of people with that are uninsured. You can see that people with severe mental illnesses are uninsured prior to healthcare reform at a much higher rate than people with no mental health diagnosis. Here, just to give you a quick snapshot in a different frame for substance use disorders, you can see, and this is why the expansion of insurance to people at different levels of the federal poverty level are particularly relevant in the context of substance use disorder treatment and access based on need for services. Now, I want to switch into Parity and the changes that are underfoot in the context of the Affordable Care Act. So the Domenici-Wellstone Mental Health Parity and Addiction Equity Act was passed in 2008. This was a major change with regard to efforts that had been in place for 15 years in Congress in many states to try to do away with the differential coverage for mental health and substance use disorders in comparison with private insurance for other health care. This law equalized financial requirements in group insurance markets, deductibles, co-payments, co-insurance for mental health and substance abuse in the context of other healthcare services. It eliminated these in the context of the Mental Health Parity Law of 1996, lifetime dollar limits, annual dollar limits. This law extended that to substance use. It's important to note that this was not a mandate. You have to provide mental health services to be able to be required to provide those services at parity, but most private employers were and are providing mental health services. And this issue of it not being a mandate really changes in the era of the ACA because it is a mandate in the context of the ACA under the terms of the Essential Health Benefit Package. This applied to out-of-network coverage. And the key, and one other thing is under the regulations, there was a provision that was called the non-quantitative treatment limit provision, which basically said it's not just your coinsurance that needs to be equal. All of the other things related to a person's insurance design, that is prior authorization, utilization review, the adequacy of provider networks, these need to be treated equally as well. And the research suggests to us that one area where you get a real impact of these parity laws is in the context of financial protection, out-of-pocket financial protection for families. And I always think of the story that Paul Wellstone used to tell us his motivation for sponsoring this legislation prior to his death. He talked about his brother who had what then was called a major mental breakdown when he was at college. He was institutionalized for a period. He got better. He went on to graduate from college. It took his parents 20 years to pay off the accumulated medical bills. So this area of financial protection is what this is all about. Moving quickly, hard to do this in 15 minutes, but moving quickly into the ACA, the cornerstones of health reform are increasing coverage through expansion of public programs, reform and redesign of insurance markets and delivery system and payment reform. All three of these components have major implications for mental health and substance abuse treatment and financing. And Medicaid expansion in the 25 and growing potentially states that are doing this is carrying the lion's share of this in terms of expansion because of the income thresholds of individuals with mental health and substance use disorders. The exchanges are doing some of the work, but it's really in Medicaid expansions that we see a lot of change. And the movement of individuals with mental health and substance use disorders who are childless adults is a really big piece of this. There are also a variety of different changes under the ACA that I won't get into in detail, but relate to integration, prevention, workforce, payment, and organizational change. And I'll just mention a few that are delivery system reform oriented. The Medicaid home health option that is really allowing for different types of services that haven't been traditionally financed on the insurance side, but that are extremely important to coordinating care for individuals with mental health and substance use disorders, co-location grants, changes to the home and community-based waiver program, facilitating access to services for these individuals. The yet unmet promise of bundled payment and accountable cares, and real serious questions about whether both the delivery system for mental health and substance use and the individuals impacted by those delivery systems are truly being integrated in accountable care. There are big questions and concerns related to this. And then financial integration demonstrations, like the demonstrations occurring in eventually close to 20 states to integrate Medicare and Medicaid for the dually eligible disabled population, many of which in the state of Massachusetts, where I've looked at 70% of dually eligibles that are moving into these integration models have mental health problems and are in need of treatment for those issues. Quickly, the ACA has a lot of provisions related to criminal justice that have not gotten a lot of attention. Most importantly, the substantial portion of newly eligible Medicaid expansion individuals who will be who are jail involved, that individuals with in jail pending disposition for the first time can preserve their Medicaid benefits. Medicaid can pay for hospital services in the criminal justice system. And these different provisions really have the potential to affect both health as well as criminal justice outcomes. There are important studies that are being launched related to looking at outcomes like recidivism. And I think that some innovative programs like Cook County is just one example, one of the largest prison systems in the country, where they're going into the jail system, doing Medicaid enrollment and intake, and then trying to take it that next step to connect people that have mental health and substance use disorders with treatment in the community. You're maintained on an antipsychotic when you're in prison, you're detoxed when you're in prison, then you're thrown out into the community with maybe months to wait typically to get back onto Medicaid, or just to be enrolled in Medicaid for the first time due to the expansion of these laws, and creating that continuum of care is critical. So some final observations. Health reform for mental health care, in my view, is historical, on par with the creation of Medicare, Medicaid, social SSI. Parity is a part of this. Integration is a part of this. Medicaid is a driver here. And some takeaway points: mental health is not a specific predictor for violence. Thus, many mental health system approaches that we're talking about are unlikely to be fundamentally effective in reducing violence, but there are targeted ways that policies may help within certain subgroups. And there are lots of good reasons beyond violence reduction to really build a robust mental health system. There are issues for disabling mental illnesses related to income support, housing support, employment support that I don't have time to talk about, but they're critical. And finally, how the broader public thinks about the population with mental illness, as I said at the beginning, matters greatly for system change. And here quickly I'll show a study that I am just completing. This is an experiment similar to Paul Applebaum talked yesterday, or in her slides, we heard about the General Social Survey. And what they did was they exposed individuals in the public to vignettes about someone with schizophrenia and then asked them all sorts of questions about them. What we have done in the study, along with Howard Goldman, Bernice Pescasolito, these are my collaborators on this study, is we've exposed people to these vignettes from the General Social Survey, and then the same vignette where the person is effectively treated. They are in recovery. They are able to live meaningful lives. And these frames, this reframing of mental illness as effectively treatable really changes some of these very poor measures that I showed you at the beginning of my talk related to social distance. 29% willing to marry in the family to 44%. Willing to work closely, 43% to 66%. So I'll end with a quote from Steve Sharfstein, right up the road. We've talked about Baltimore some already this morning. He says, will we ever see an end to the stigma that's associated with mental illness? No, not as long as there are untreated, delusional, disheveled, threatening, homeless individuals on our streets and high-profile media examples of violence. And the services delivery system can really play a role in changing this. Thank you.